as usual, Adas will drive the slide.
Go ahead, James.
Okay, thank you everyone, and thank you for joining us for the webinar today. We really apologize for being late. The technology has worked perfectly for the last 1 hour, but there was a glitch for the last few minutes. So welcome to this pre-launch webinar on the upcoming WHO technical statement. Just to introduce myself, my name is James Carey. I'm the coordinator of the WHO Human Reproduction Team that is working on the family planning. And for this pre-launch webinar, we have shared with you an embargoed copy of the statement that we'll be issuing on the 2nd of March. And we have also shared with you a copy of frequently asked questions that we have developed. For those of you probably not familiar with the process for WHO, the statement will be issued in just the format and with the content with which we have shared with you, but we really are also looking forward to your input for our responses on the frequently asked questions, or maybe on other questions that you feel are not included. The other thing is that during the webinar, if you raise up your hand, then others will be able to unmute, and also alternatively, you can enter any comments or observations that you have or questions in the chat box. And just to start off first, to acknowledge the participation of our various partners. And we do have the USA, we have AVA, we have the Organization of Women Living with HIV in East Africa, we have the GFID, and we also have a lot of the research partners are here with us today. So those of you that have mentioned, and others I know who may be online that I may have failed to recognize, I think also the US CDC will be online. We are a small group. We have just about 20 participants on the line, so I think we'll have some good discussions at the end. And so before taking too much time, because we are already behind schedule, I would like to ask my colleague, Dr. Marilyn Garfield, who led the process of developing this statement, to come and take us through the statement. Thank you.
Thank you very much, James. Everyone can hear me. Before I begin, I would like to thank the members of the Guideline Development Group and the external peer reviewers whose input shaped the guidance statement on hormonal contraceptive eligibility for women at high risk of HIV infection. Also, I'd like to particularly thank Dr. Sharon Achilles, Lauren Thaxton, Maria Rodriguez, Chelsea Palmas, Caitlin Kennedy, and Roger Chow. During the consultation, they gave presentations that were instrumental in the Guideline Development Group coming to its conclusions, which you see in the statement before you. So next slide, please. Great, thank you. As many of you are aware, for more than 20 years, WHO's Department of Reproductive Health and Research has produced the Medical Eligibility Criteria for Contraceptive Use Guideline, or as we call it, MEC. And on June 1st, 2015, WHO issued the 5th edition of this document. The MEC is an evidence-based guideline that provides more than 2,000 recommendations on the safety of 25 different contraceptive methods for women with certain medical conditions or personal characteristics. And in particular, this guideline includes recommendations on contraceptive eligibility for women at high risk of HIV infection. Next slide, please. Although some or perhaps all of you are already familiar with the format of the MEC's recommendations, I'd like to just quickly review the meaning of the 4-category scale that is used to indicate eligibility. Category 1 conditions indicate, or characteristics indicate, that there are no restrictions on the use of a particular contraceptive method. Conditions classified as Category 2 indicate that the method can generally be used, but careful follow-up may be required. Category 3 conditions are those that require careful clinical judgment and access to clinical services, while Category 4 conditions are those that present an unacceptable health risk, and the method in question should not be used. Now, in certain situations, separate recommendations will be made if eligibility differs according to whether the woman is initiating or continuing to use the method. In settings where resources for clinical judgment are limited, this 4-category scale can be simplified into 2 categories. Thus, women with a condition classified as Category 1 or 2 can use the contraceptive method, whereas if she has a Category 3 or 4 condition, she shouldn't use the method. Next slide, please. I'd like to quickly review the current recommendations that are presented in the 5th edition of the MEC. So as you'll see from this slide, currently there are no restrictions on the use of combined hormonal contraceptive methods such as pills, the patch, the vaginal ring, or the combined injectable, as well as there are no restrictions for the use of progestogen-only contraceptives such as pills, injectables, and implants. And this is all for women who are at high risk of HIV. Now, women at high risk of HIV can also generally use the levonorgestrel-releasing IUD. And also, it's particularly important to note, as you'll see on this slide, for the injectable contraceptive methods that are abbreviated here as DMPA and NET-N, that while they are Category 1, you can see there's an asterisk there indicating an important clarification. I think many of you on this call are already aware of this. This clarification was issued initially in 2012, and it was updated in 2014. And what's important to note is that here we are indicating to programs and policymakers that that women who are at high risk of HIV and using progestogen-only injectables should be informed that available studies on the association between the use of this method have important methodological limitations that can hinder their interpretation, and that this was discussed not only in 2012 and 2014, and it was agreed that the epidemiological data did not warrant a change in this recommendation. But given the importance of this issue, women at high risk of HIV should be informed that progestogen-only injectable use may or may not increase the risk of HIV acquisition, and that women and couples at high risk of HIV acquisition who consider the use of progestogen-only injectables should also be informed about and have access to HIV prevention measures, including male and female condoms. Now, I just want to note that you'll see on the table there's a circle, and I just want to mention that in this consultation, the group did not consider recommendations for the levonorgestrel-releasing IUD for women who are at risk of HIV infection. So just to say that that Category 2 is upheld. The rest of this presentation will address the methods within the red circle. Next slide, please. So following the release of the 5th edition of the MEC in 2015, WHO became aware of new data that was published since 2014. Consequently, WHO commissioned an update of the systematic review that supported the 5th edition recommendations. And this systematic review offers a synthesis of the body of evidence on hormonal contraception, HIV acquisition in women, and was published as an open access document in the journal AIDS on the 9th of August last year. To summarize briefly, the review identified 10 new studies, of which 5 were considered informative, but with important methodological limitations. And based upon the results of a meta-analysis of the data from higher quality studies that was presented in the systematic review, the risk of HIV acquisition among women using DMPA compared with women not using hormonal contraceptive methods was a hazard ratio of 1.4, with 95% confidence intervals surrounding this estimate ranging from 1.2 to 1.7, suggesting statistical significance. Additionally, the review concluded an important next step would be for WHO to determine whether it should reconsider its global guidance on DMPA for women at high risk of HIV infection. Now, in conjunction with the publication on August 9th, WHO issued a statement announcing that it would convene an expert review group later in 2016 to examine the links between the use of various hormonal contraceptive methods and women's risk of HIV infection. Next slide, please. During the early December consultation, WHO convened a group to review new evidence on the risk of HIV acquisition with hormonal contraception as presented in the systematic review, and as appropriate to review its recommendations that were published in the 5th edition of the MEC. Now, the review process followed the standards and requirements that are specified in the WHO Handbook for Guideline Development, but in addition, to provide critical contextual information that could inform the discussions, a variety of topics were also presented. So, for example, results from a decision analysis that modeled competing risks of unintended pregnancy, maternal mortality, and HIV acquisition risks, as well as results from a very brief survey of programs' interpretation of WHO recommendations for women at high risk of HIV. Also, there was a panel discussion organized amongst program managers to understand their perspectives on the topic as leaders of contraceptive programs. Additionally, there was a summary of the systematic review findings, and then also there was a review of the biological plausibility and potential mechanisms that might link hormonal contraception and HIV acquisition. Lastly, in addition to these presentations, the Guideline Development Group considered a variety of factors when coming to its conclusions. So they considered not only the quality of the evidence that's presented in grade tables, which will be shown in subsequent slides. They also considered the values of preferences of contraceptive users and healthcare providers. They weighed the balance of benefits and harms of contraceptive use, considered the importance of contraceptive choice, considered the imperative of equity and human rights, the acceptability of recommendations, and also the feasibility of implementing any WHO recommendation. Next slide, please. Now, for this slide here shows the data that was considered for combined hormonal contraceptive methods. So combined pills, the patch, the vaginal ring, and the combined injectable contraceptive. Now, for these recommendations, the Guidelines Development Group considered evidence from 11 cohort studies that were deemed informative, but with important limitations. And this data represented data from more than 43,000 women. No studies on the combined patch, vaginal ring, or combined injectable were identified. So these studies is really presenting on risk among women using the combined oral contraceptive pills. In summary, 10 of the studies found no statistically significant association between the use of combined oral contraceptive pills and risk of HIV acquisition. But one study reported a marginally statistically significant risk. However, the overall quality of this data was rated as low to a moderate quality. And the adjusted hazard ratios among these studies range from 0.66 to 1.8. And none of the studies reported a statistically significant increased risk of HIV acquisition among women using combined hormonal contraceptives compared to women not using hormonal contraception. Next slide. Therefore, based on this evidence, the Guideline Development Group determined that the current NDC recommendations for combined hormonal contraceptive methods among women at high risk of HIV should be upheld, meaning for all of these methods, they remain a Category 1, indicating there are no restrictions on the use of these methods for women at high risk of HIV infection. But please do note that we have updated the evidence summary in the table so that this is up to date with the latest evidence. Next slide, please. So now I'll move to our discussion of progestogen-only contraceptives. Next slide. I'll first start with the review of data on contraceptive implants. For progestogen-only implants, meaning levonorgestrel or etonogestrel-releasing implants, the review identified 2 small studies that assessed this acquisition risk among women using levonorgestrel implants. And these 2 studies were deemed informative, but they did have important limitations. And they did not suggest an elevated risk, although the risk estimates, as you can see from the 95 confidence intervals, are quite wide and imprecise. While one study reported no association between the use of, and one study also showed no association between the use of progestogen-only pills and increased risk of HIV acquisition. Next slide, please. Now this slide shows the grade table for progestogen-only injectables, or rather DMPA administered intramuscularly or subcutaneously and norethistron enantate. They comprise, for these methods, 13 observational studies were identified and were considered to be informative, but with important limitations. But together, the data from these studies continues to show some association between the use of progestogen-only injectables and risk of HIV acquisition, but it remains unclear whether this results from a causal relationship or methodological limitations of the data. I'd like to draw your attention to the blue arrows on the right side of the slide. The upper arrow points to the adjusted hazard ratios that were pooled among the 9 studies that examined HIV acquisition risk among women using DMPA versus women who were not using a hormonal contraceptive. From this, you can see that the adjusted estimate is 1.4 with confidence intervals the confidence interval ranging from 1.23 to 1.59, and the I-square value indicates that across these studies there was low heterogeneity. So this indicates that there is a statistically significant increased risk of HIV acquisition among women who use DMPA compared to no hormonal contraceptive method. The arrow below indicates the adjusted hazard ratio that is pooled across the studies, and it shows that while the hazard ratio was above 1 at 1.15, the 95% confidence interval includes one suggesting a lack of statistical significance. And finally, I'd like to draw attention to the last row, which presents data from head-to-head comparisons between women who use DMPA and norethistron enantate and their risk of HIV acquisition. And from this comparison, one cohort study showed a hazard ratio of 1.3, and confidence interval did not include 1. And then data from an individual patient data analysis also showed that there was an increased risk among women who used DMPA compared to those that used norethistron enantate. Next slide, please. In addition, to the data that was reviewed in the grade tables, a systematic review of the qualitative and quantitative literature on women's and providers' values and preferences regarding contraceptive use was considered. And this systematic review searched a large group of databases and looked for studies during a 10-year period. There were no language restrictions on the publications. Many citations were identified, and 206 of these citations actually were included in the review. Unfortunately, there was no direct literature that actually spoke to women's values and preferences regarding the use of contraceptive methods and any increased risk of HIV acquisition. But from this, systematic review, what we can conclude is that women's values and preferences centered on a variety of key themes. One being that they want a variety of options, contraceptive methods that are easy to use, have few side effects, and that are effective. They also many studies found that a variety of contextual factors were important in shaping women's values and preferences. For example, the impact of providers' counseling, the quality of the counseling, and opinions of social networks also influenced women's decisions about contraceptive methods. Next slide.
This is a big part of the cord. Can you hear the closest to your mouth?
Yeah. Okay. Can you hear? Is that right?
That's a try.
Great. Okay. Also, what was unique in this consultation, and had not been done yet in any preceding consultation of the NEC, was we purposely looked at a variety of key factors that would determine the recommendation. So we not only looked at the quality of the evidence, which, as we've seen from earlier slides, ranged from low to moderate quality, but also the group really thought through the benefits of harms of contraceptive the two methods in question, and these other issues that are listed on this slide. And what I think is important for everyone to note is that the group very thoughtfully thought through the balance of benefits and harms, and that the Guideline Development Group noted that for individual women, the risk-benefit ratio would be different, and that it's really essential that informed decision-making be utilized by women who are considering injectables, and all contraceptives for that matter. They also noted that there's still there's uncertainty in the scientific data as to whether there's an association of increased risk, and that the possible increased risk of HIV acquisition was outweighed by the very real risk of maternal mortality and morbidity associated with unintended pregnancies. As noted in the earlier slide, values and preferences played a key role. The group strongly advised that women have the right to informed decision-making, and that women preferred to have a choice of methods, full information about the benefits and harms, and for making a final decision, they want to do this in conjunction with a provider, that there needs to be shared decision-making going on. So the group determined that women who use progestogen-only injectables generally like them for the reasons that we identified in the systematic review, and feel comfortable using them after counseling, and that women's preferences for methods are limited by what they have knowledge of, what is available to them, and other factors that foster a limited access. So offering women a choice of a range of methods is important from both a health and human rights perspective, and that providers should support optimizing, and programs should support optimizing informed contraceptive choice and the availability of a wide range of contraceptive options. it was universally agreed that this is a public health priority, that not only hormonal contraception and HIV together, the risks of unintended pregnancy, it's a common problem globally, and unintended pregnancy, the risks are often highest where maternal mortality and severe morbidity are also very common. Equally, the group really drew upon recently released human rights guidance from WHO in coming to agreement on what the recommendation should be. In addition, there was a great deal of discussion about the feasibility of the recommendations and how it is of paramount importance that there's clear communication on this topic. And this was underscored repeatedly by representatives of affected populations, program managers, and from our WHO's member states. And it was acknowledged that the prior WHO guidance, which included the clarification statement with the NEC category 1 rating, was often overlooked and poorly understood. So as a result, this feedback was incorporated into the updated guidance. Lastly, although many guidelines of WHO do consider resource implications, because the MEC is really focused on the safety of specific contraceptive methods, opportunity costs and resource implications are not formally assessed because the costs of contraceptives may vary widely in different regions. Next slide. Lastly, I just want to point out that a very important presentation was also given during the consultation to help inform the decisions that were made. We had a review of the plausible biological mechanisms, and where the group was reminded that progestogens provide the component that offers the efficacy of a contraceptive method, and that progestogens have an impact on many aspects of human physiology. Also, we were reminded that animal studies, while they show that epithelial lining of the female genital tract occurs, we do not. There are few human studies on this topic. Now, there have been postulation that there could be alterations in the microbiome, or the vaginal flora, but currently the data does not support this thinking. And while there is limited data, certain progestogens can enhance HIV replication and possibly increase HIV susceptibility markers in the genital tract and may impact human immune response. There's this real need for more precise measurement of the type of progestogens in question, the concentration, and the mode of administration. And all of these aspects we really need to have greater information so that we can understand whether or not there is a biological or immunological effects from the use of DMPA. Next slide, please. So in conclusion, the group, taking this data together, the group upheld the recommendations for progestogen-only pills and the levonorgestrel etonogestrel releasing implant. However, the group determined that for DMPA, whether intramuscularly or subcutaneously administered, and for norethistrin and enantate, they determined that this recommendation should be an MEC Category 2. And in making this recommendation, they also came up with the following clarification, that there continues to be evidence of a possible increased risk of acquiring HIV among progestogen-only injectable users. Uncertainty exists about whether this is due to methodological issues with the evidence or a real biological effect. In many settings, unintended pregnancies and/or pregnancy-related morbidity and mortality are common, and progestogen-only injectables are among the few types of methods widely available. Women should not be denied the use of progestogen-only injectables because of concerns about the possible increased risk. Women considering progestogen-only injectables should be advised about the possible increased risk, about the uncertainty about whether there is a causal association, and how to minimize their risk of acquiring HIV. We also below have an updated summary of the evidence that helped inform that recommendation. Next slide. So in conclusion, WHO recommends that for women at high risk of HIV, there should be no restrictions on the use of combined hormonal contraceptives, progestogen-only pills, or progestogen-only implants. And for women at high risk of HIV infection, they can continue to use DMPA, whether it's intramuscular or subcutaneous, and norethistrin and Ante. As you've seen in the earlier slide, these methods as injectables are now an MEC Category 2. And when the Guideline Development Group was formulating this recommendation, they recognized the imperative that the human rights of women and girls for contraceptive choice and informed decision-making was imperative. And that also in making this recommendation, it's essential that there's clear communication that full informed counseling needs to occur. It was recognized that the earlier recommendations had actually not led to this intended goal of full informed decision-making. So as we've seen, women should not be denied the use of progestogen-only injectables. However, they do need to be advised about the possible increased risk of HIV infection and also about the uncertainty of whether or not there's a causal association. And as we all know, consistent and correct use of condoms, whether male or female, is critical to protect against sexually transmitted infections and HIV, and also prevent HIV transmission. Next slide. Now, what does this mean for policies, programs, and providers? Well, we at WHO believe programs can continue to offer all methods of contraception to women at high risk of HIV infection. And we offer a variety of resources that can complement these recommendations, such as a training resource package, some counseling tools, and some provider reference materials. We also underscore that it's imperative that comprehensive contraception and HIV information is offered equally to everyone. And that it goes without saying, contraceptive counseling is a core feature that supports informed choice as well as informed decision-making. It's also essential that high-quality family planning and HIV services are integrated. And if this occurs, reproductive health of all individuals will be optimized. We urge national programs to expand upon the range of available contraceptive methods, family planning method options for all individuals, and particularly for women who are at high risk of HIV infection. Next slide. Lastly, WHO remains committed to continually review the body of evidence that supports the recommendations on contraceptive eligibility, and particularly for women at high risk of HIV. And we continue to strongly support the need for further research to address not only the epidemic of HIV, but also the epidemic of unintended pregnancy. Thank you.
Thank you very much, Mary Lynn, for that presentation. And we are now open for questions. And those who would like also to ask questions can lift up their hands, and we'll be able to unmute your microphone. But briefly, I just want to go through the communication activities that we'll be having as a follow-up to this pre-launch webinar. So the first, the aim of these communication activities is that we'd like this guidance to be implemented in the countries, but at the same time we want to ensure that there is no unintended consequences of this guidance, that has the impact that we would like it to have. So we are planning to first hold this pre-launch webinar. We've already held one with the UN and the countries. And we've also sent you a set of frequently asked questions with proposed responses, and we would really appreciate your input on this. And if you are not able to raise the issue in this webinar, you can always feel free to email us your suggestions. At the time of the release, we'll also have a web story which will put in layman's language what we have included in the statement. And also we will put the launch on social media. We hope to follow up this webinar with one for the Francophone countries in French, and we will try to hold it either before 2nd of March or soon after. Since we'll be having several webinars to explain this statement, we will also avail the recordings of those webinars for those people who would be interested in following up and getting more detail of what is being discussed. In country follow-up, we'll be following up with the countries to provide support both for communication and implementation through our WHO country offices, also with the UNFPA and other UN organizations that are working on health, that are referred as the H6 partners. And also, I believe we will partner with you all that are in this call in terms of providing support at the country and the global level to communicate this guidance. And then on the next slide, I just highlight, I won't read through this, but the frequently asked questions cover three main areas. One of the areas is that the communication, that there's been a change in guidance, highlighting what the change has been, why the change has been, and the process. And the other part explains the expected programmatic and service response. I won't read through this, and this highlights what Berlin has highlighted in her presentation. And the other area covered by the frequently asked questions is on the areas of research, highlighting that we will continue to monitor the evidence on this issue, but also really the need for clinical trials to provide more information, particularly about possible causality, explaining the association that we are seeing, and also research to clearly elucidate women's preferences and values in contraceptive decision making. So now we are open for questions. We still have about 5 minutes, and I will go ahead and hand over to Marilyn to respond to the question.
Great. Thank you, James. Let's see, where is the first one? Okay, so let's start with the, excuse me. To first start with hopefully a quick question, an easy question. WHO will make the statement public on March 2nd and on our website. And, yeah. And as far as for the precise, and so the next question was about DMPA binds to glucocorticoids, and yes, you are correct. According to the presentation we received, that there are specific receptors, and quite a few receptors. So we can respond in greater detail later. There's a question of, would WHO consider updating all the mentions of HIV prevention to be consistent with UNAIDS definition of combination prevention, which identifies PrEP as a core element for many groups of HIV-negative women who are also being offered DMPA. I think that's something, yes, we can do that. And what time, we've got another question about what time on March 2nd. I'll actually have to defer to my web colleagues. I'm assuming that it would be in the morning, so that Central European time is, I would assume it would be available by 10 a.m. Central European time, something to that effect, so that would be like 4 a.m. in the United States. Another question is, how does WHO recommend provision of this information to women as a part of HIV counseling? Is it a side effect? Should it be provided to all women couples who seek family planning services, or only those who choose DMPA? I think to begin with, counseling is a core component and should always occur, irrespective of whether or not a woman is at high risk of HIV and whether or not she's considering a particular method of contraception. But as far as, and we will be looking at the counseling tools we do have to update them now that this launch has taken place.
Marilyn, there is a question. The line is open.
Oh, sorry. Saad from USA.
Yeah. Okay. Where's the question from Dr. Saad?
He's going to speak.
Oh, okay. Great.
Saad, go ahead and ask a question, please.
So, Dr. Saad, you can go ahead and ask your question.
Yes.
I believe you have been unmuted.
No, I can't. Unfortunately, I cannot hear him.
We can't hear Dr. Saad, so let's just continue.
Okay. Okay. I'm terribly sorry, but we can't hear your question. So let's see. We'll go up to, let's see if we could go up just a teeny bit. Jennifer Mesa, it looks like, has asked a question. Not sure if I have the, yeah, if we could go up like this. Okay. Okay, is there another question up here above that? Yeah, let's see. Okay, so now two questions from Jennifer Mason. Okay, first of all, can we provide more details on the plans for development of derivative communication products and support to member states and sexual reproductive health focal points to ensure that the guidance is fully and correctly implemented into national policies and programs? Well, just to say that in the next couple of weeks, we're going to be embarking on that. I think we've been a bit full on with getting the statement prepared and also getting the statement prepared in French and in Portuguese. So we will give attention to that, and we hope to have it as soon as possible. As far as the technical statement and FAQs do not contain a clear statement on the importance of condom use for women at high risk of HIV who choose to use. Progestogen-only methods. Let's see if we could scoot down just a bit. The previous technical statement added this sentence due to inconclusive nature. Okay. Well, what we at least have in the technical statement is what the advisory group advised us, and it was approved through all channels at WHO. So the technical statement does remain as it is, and throughout the NAC, we highly note that use of condoms is essential to prevent against STIs and HIV because no other contraceptive method offers that protection. We can, through further communication products and counseling tools, can definitely highlight that. and we will do so, but the technical statement stands as it is. We've just now seen the question from Dr. Saad, so will WTO provide guidelines to define women at risk? Unfortunately, this question came up in the consultation, and we were strongly advised not to, that this is a contextual issue and that this is for, that unlike, I think, documents coming out of our Department of HIV, we do not define what determines a woman to be at high risk of HIV infection.
So I think we are just about 6 minutes over the time, and we apologize for starting a bit late. And we really appreciate your participation in the call and also for the questions. We've seen a lot of input, particularly from the frequently asked questions, and we will endeavor to input these your suggestions. For those who may not have had a chance to give their suggestions, please also do email us any issues that you'd like to be added on the frequently asked questions. And we thank you very much, and do have a good morning and a good afternoon for those. I know some of you have joined us very early in the morning and others late in the afternoon. And it's bye-bye from us. And thank you for joining our call today. Bye-bye.